Hello, my name is Patrick Vargo. I'm a cardiac surgeon and part of the Aortic Center at Cleveland Clinic. Every year we perform thousands of cardiac and aortic operations, and we are the highest volume center in the United States. I would like to show you how we treat an aortic aneurysm that starts just above the heart. And because of where this aneurysm is, it affects the aortic valve. So you may be interested to see how do we fix the aorta and how do we repair the aortic valve. This is a very common scenario in the way a person discovers they have an aneurysm. Often they have little to no symptoms because aneurysms in the chest rarely have symptoms unless they are in the process of rupturing or tearing, which is an emergency and often causes pain. Many patients will be screened with a CAT scan or an echo because aneurysms may run in the family, or they may have gotten one of those tests for an unrelated reason and incidentally found the aneurysm. Occasionally, an aneurysm in the part of the aorta near the heart will cause the aortic valve to stretch out and become leaky or regurgitant. This sometimes causes symptoms like shortness of breath or fatigue. So in this scenario, a 51-year-old man came to my clinic. He had incidentally found an aneurysm. He was screened as they run in his family. He was asymptomatic, and he's a very avid hiker and outdoorsman. And this is something he was very concerned about because he didn't want to be on a lot of medications and he wanted to get back to his active lifestyle. Shown here is the CAT scan that he had received that originally diagnosed the aneurysm. So what is an aneurysm? An aneurysm is a ballooning out of a blood vessel or a dilation of the blood vessel. The aorta is the largest artery in the body. It exits the heart and travels throughout the torso and abdomen. As you can see here, this patient has an aneurysm in the ascending aorta and root. The root is the aorta as it attaches to the heart, and it measures 55 millimeters in this gentleman. With that information, he was told to go see a surgeon and to have this fixed. In this moving picture here, this is an echo, which is an ultrasound of the heart, showing the function of the heart as well as the valves and how they're working. Specifically, what this is showing is the aortic valve and the three leaflets opening and closing. That bright jet in the middle, there's a little dot with blue and yellow and red in the very center of the opening and closing valve, is actually a little bit of regurgitation, a mild to moderate amount. That regurgitation developed because the leaflets, which are attached to the aortic aneurysm, are being stretched apart, and blood can go backwards through the valve back into the heart after it's ejected out. We know that as aneurysms get bigger, their risk for rupture or tearing or dissecting increases. For aortic aneurysms in the chest, the risk dramatically goes up as the aneurysm grows from 5 to 6 centimeters. That seems to be the area of an inflection. When a patient has an aneurysm, we consider many factors: family history, genetic screening, patient size, but in general, we intervene when the aneurysm reaches in the 5 to 5.5 centimeter range, prior to that real increased risk for rupture. So this patient was sent for aortic root surgery. The main message for a patient like this is that they need to have an aortic root surgery to prevent a life-threatening rupture or tear. That operation is both an aortic repair as well as an aortic valve repair for the reasons that we'll see. In this surgery, we excise and replace the diseased aorta with a synthetic tube made out of a material called Dacron. Because we cut out the aneurysm, this eliminates the risk for sudden rupture or tear of the aortic aneurysm. It's no longer in the body. In an elective, non-emergency setting, this is a very safe operation. We perform it with a fraction of a percent for risk of death here at the Cleveland Clinic. The aortic root is at the base of the ascending aorta where it joins the heart, as I previously mentioned. Where it joins, there is a one-way flapper-type valve called the aortic valve. It prevents backflow of the blood back into the heart. The aortic valve is attached to the wall of the aortic root. In this area, where the aneurysms form, if you would treat the aneurysm, you have to also treat the aortic valve because it is directly attached to that aortic wall. The aortic root is also where the coronary arteries come off to deliver blood flow to the heart muscle. There's a right and a left coronary artery that branches off the aortic root just above the aortic valve. When you replace the aortic root, you can also replace the aortic valve. Shown here is a mechanical valve on the left-hand side and an animal tissue on the right-hand side, either cow or valve. Unfortunately, there are drawbacks to both these valve types. Mechanical valves make an audible clicking sound, and they require lifelong blood thinners to prevent the formation of clots that can cause strokes. Animal valves do not require blood thinners, but they do have a limited durability. In young patients, they may only last approximately 10 years. Fortunately, there is another option. In a David procedure, often called an aortic valve reimplantation or a valve-sparing aortic root replacement. We preserve the native aortic valve that a person is born with. This involves sewing it into this new synthetic aorta as we replace the aortic aneurysm. Doing this avoids blood thinners that you need with a mechanical valve, but also it avoids degeneration that we see with animal valves. In a study out of Cleveland Clinic, we looked at patients that underwent the David procedure, and we found excellent results. Again, this operation was performed very safely with a very low risk for death and complications. When we looked at the durability of these patients, 95% of them continued to function well in the long term in patients with and without known heritable syndromes causing aneurysms. While we can save most normally functioning aortic valves, and even some of those that are quite leaky, there are some valves that are not amenable to being saved. Those are the valves with very severe damage, usually thickening and hardening, calcification. This is shown in the lower picture on the right there, a normal valve, and then to the right of it there's a cartoon diagram of a thickened valve with calcification on it. How do we fix the aneurysm and how do we save the aortic valve? I will walk through the main steps of the operation, showing you how I do it. I would like to show you some artist drawings as well as photo and videos from actual surgery. The first step is to transect or cut the aorta and excise out the aneurysm. I'll leave behind a thin rim of the aorta where the leaflets attach to it, and we call these the valve posts. I'll also disconnect the right and left coronary artery attachments, leaving a thin rim, and we call these coronary buttons. So here is the aorta being cut open. The aneurysm is to the right side. You can look down into there and see the valve. Right here, the scissors are cutting the right coronary button, or the right coronary artery where it attaches to the aneurysm. We're cutting that away and freeing it from the aneurysm. There's a little bit of blood coming backwards out of that that's being suctioned away. After we free up this right button, we'll then free up the left button. These will be reattached later after we've completely replaced the aneurysm so that the heart can continue to get blood flow. And now that we've retracted that right button out of the way and freed it from the aneurysm, we'll do the same to the left coronary artery. After these are completely cut away from the aneurysm and the valve, we'll cut through some of that thin tissue, mobilize these buttons so that they can be moved around and then later put back into the appropriate place without any kinking or tortuous angles. Finally here, we'll cut away the remaining rim of the aneurysm, leaving just a thin amount of aorta where the leaflets attach directly to the aorta. At the top of each of those posts, where the leaflets are attached, are stitches that we'll use to help re-implant them and also to retract them while we're working on the aorta. The next step is to replace the aorta, or actually insert the prosthetic synthetic tube that will be our new aorta. To do this, we'll place stitches below where the valve attaches. We'll put it below the annulus is what that's called. And they'll pass out, and then we'll use those stitches to anchor the new synthetic aorta and tie them down around the opening to the valve. In many repairs, if a valve is leaky, this helps to repair it just by putting it inside a normal tube that's the appropriate diameter for the valve to function properly. So we return to the operation, and we're placing stitches now below the aortic valve leaflets and out the other side. We'll go all the way around the opening using somewhere between 8 and 12 stitches generally. And after we get all the way around, we'll then begin to pass them through our synthetic aortic tube. This is a material called Dacron, which is woven polyester, and it is strong enough that it will not rupture or tear and can function as a new aorta. Once all the stitches have been passed through, we'll seat that down over the valve, which will now be inside of it, and we'll tie those down, anchoring this new aorta to the heart. Once we've secured the new aorta down to the heart, we have to resuspend the valve within it. What I do is use a running stitch and sew the rim of aorta that's still attached to the valve to the inside of the graft, thereby re-implanting the aortic valve. So using a curved needle with a stitch attached to it, which is a permanent non-dissolving stitch, we'll secure the native aortic valve to the inside of that synthetic aortic tube. This will allow the valve to function normally, opening and closing, and preventing blood from leaking backwards into the heart. We'll go up and down each post all the way around until we've made our way circumferentially around the native valve. To reconnect the coronary arteries, I'll cut 2 small holes in that synthetic aortic tube. I'll then sew each coronary back to the aorta to reattach it in its original position, one at a time. Finally, I'll sew the synthetic aortic graft to normal-sized healthy aorta beyond where the aneurysm was. Here's a little bit of saline to test the competence of the valve, showing 3 leaflets. This is a device used to cut the synthetic aortic tube and make a hole or a fenestration where the left coronary artery can be reattached. Again, we're using non-dissolvable stitches that will be passed through the graft and then the aorta that's surrounding the coronary artery. There's a little strip of bovine pericardium that's used as a buttress to help prevent any bleeding and strengthen the wall of the coronary artery as it reattaches. Here we're doing the same thing for the right coronary artery. Now that both coronary arteries have been reattached, we're sewing the synthetic aortic tube to normal-sized healthy aorta beyond where the aneurysm was. Again, using a strip of bovine pericardium to buttress the native tissue. In some instances, one of the aortic valve leaflets is longer than one of the others or redundant, and these leaflets can be plicated or adjusted using different sutures prior to closing that aorta. This is actually a bicuspid valve, where one leaflet is much longer than the other leaflet of this bicuspid aortic valve. To make them the same length and to come together or coapt normally, we'll use extra stitching to plicate that centrally. This is in fact a picture of that valve that was just plicated. While most aortic valves have 3 leaflets, some people are born with a valve that only has 2. These are called bicuspid aortic valves, and they are often associated with aortic aneurysms. As long as the leaflet tissue quality is healthy, a David procedure can still be performed in these patients as well. So using this operation, the David procedure, we can excise the aneurysm, keep the valve, and repair it if necessary. Importantly, patients can return to a normal life, all while avoiding blood thinners. David procedure and complex aortic valve repair are specialties within cardiac surgery. If you are a patient with an aortic root aneurysm, you want to make sure you undergo a safe repair that preserves your valve. At Cleveland Clinic, we perform this specific operation hundreds of times every year with excellent results. We would be happy to see you in our Heart and Aorta Center and give you the best care for a long and healthy life. Thank you.